Everybody, we'll be starting in just a few minutes here. Just going to let some people join in.
Hi, everybody. Thank
Hello.
you so much for joining.
Yeah, guys, thank you so much. We really appreciate all the support as always. We're really excited to have Kaitlin here with us. It's going to be a really good session. Just real quick, so we're gonna be watching the chat the whole time. So if you have any questions,
Hi,
comments,
everybody.
anything like
Thank you
that,
so much for
whoops. If you have any comments on the case studies or anything you want to say to Kaitlin, just let us know and we will be relaying it to her either throughout or at the end. If you guys have any questions about the quiz, it's going to be the same general format, but here's a little more on that.
So same thing at the end. We'll send out the link in the chat, and it's 5 multiple choice questions. As long as you get 4 out of 5 correct, you get a certificate.
Yeah, and I think that's everything, guys. So without any further ado, Kaitlin, it's all you. There's over 100 people here, but we probably expect a few more people to join in as you go. So I think you may be muted right now. Let me see. Oh, no, never mind. I hear you.
I think I'm here. Okay.
Yep, you're here. Okay.
Go ahead and switch over to screen sharing mode.
Yeah, absolutely.
Everything working okay?
Yep, looks perfect on our end.
Perfect. Well, welcome everyone. My name is Kaitlin. I'm a PA in family medicine. I've been out of school for a couple years now, so working for a little over a year. We're just going to go through a couple cases tonight that are kind of typical family medicine stuff that I see. We'll talk about what I do in family medicine and just talk about like PA profession in general. So a little bit about me. My bachelor's degree is from Georgetown College. It's a small school in Kentucky. My major was in health science. I was involved in Greek life, campus newspaper, and campus ministries. I then went to PA school at the University of Dayton, graduated winter 2018. Passed PANTS, which was our board exam, in January 2019. And then while I was there, I was involved in the PA Student Society. So that was basically helping our program as a whole stay connected to our state organization, our campus like pre-PA club, and any kind of fundraising or volunteer philanthropic efforts from our PA program. So that's something that, if you're interested, would probably be an opportunity for you in your PA school. My background prior to PA school, so I don't know what I got on the GRE. It's been over 5 years, so apparently they've just purged my score. I tried to find that for you all, but I don't know. As far as healthcare experience, I was a medical assistant at the campus wellness center at the college that I worked at. So that was staffed by a PA. She kind of ran it on her own. So that gave me a lot of opportunities to work closely with her, as well as to be trained in like vitals and diagnostic testings, and just real good, not only experience for PA school, but the opportunity to see what a PA did real up close. The other thing that I did in college was my school offered something called a preceptorship, which is basically like a seminar style class for pre-health students. They worked on our personal statements with us for school. And then part of that also was having like a placement in the city to get like hands-on experience for whatever pre-health profession you were going to go into. So I did that at the ER, working with PAs, nurse practitioners, and physicians. That was the other part of my healthcare experience prior to school. I initially found out about the PA profession in high school. We had an alumna come back and do like a careers in science presentation, and she was a PA, and that was the first I had ever heard of that. Prior to that, I'd kind of been thinking medicine. But so that was the first time that I heard about what a PA was, and that kind of prompted me to dig further and see, oh, hey, maybe I might like to do that too. I really like the collaborative approach to care, getting to work in a team with physicians. I never really wanted to be like a sole provider, if that makes sense. I like that we're trained in general medicine. I really like the broad scope that PAs have. And then something that I wanted to touch on is like work-life balance, because I think at least when I was applying to PA school, that was something that we heard a lot. I've come to believe now that it's more dependent on like your individual circumstances rather than something inherent in the PA profession. I think PAs can have great work-life balance or not so great work-life balance, and the same with physicians. So just something to think about. So right now I'm actually in between jobs. We recently moved across the country. So I'm in credentialing right now. So waiting for my license and DEA to kick in my new state. But I get to start in a couple weeks. I'll be staying in family medicine. So doing pretty much the same thing. But a lot of what we'll be talking about tonight is from the job that I just left. So I worked at a rural health clinic in Central Texas, and I was there for a little over a year. It's full scope family medicine, so everything from birth to death, acute, chronic, preventive visits. Got to do some minor procedures, so I actually did quite a bit of biopsies. We do injections, like joint injections, incision and drainage, like abscess and cysts, and casting for fractures. I worked with the physician and various PAs and NPs during my time there. A typical work day is 8 to 5, Monday through Friday. I would say that's pretty standard for family medicine. Occasionally we had rotating Saturday half days too. And that was more of like an urgent care type where we would just have walk-ins for Saturdays. We wouldn't take appointments. So why family medicine? So I like the variety. On my next slide, I'll have kind of an example of some of the stuff that we do in family medicine. It's not just colds and hypertension is kind of my joke. Sometimes that's the reputation that family medicine gets. I liked how it's relational, but also hands-on. So for the most part, I feel like I get to use everything that I learned in PA school. I won't say totally everything because there's some stuff I don't do at all, like obstetrics and surgery. But for the most part, all of that knowledge is staying with me and is involved in my day-to-day. So I like being able to follow my patients long-term. I like building relationships with them. And I like, getting to know the whole family, which is really what you do in family medicine. You're part of their community. The other reason that I felt kind of led to family medicine was due to the primary care shortage, and just knowing that you're meeting a need is very meaningful. So this slide, I'm not going to go down and, read these one by one or anything, but I pulled this off of the PANTS blueprint, which is like the list of kind of disorders that you're expected to know for your board exam. And these are just some of the stuff that I would say is typical for family medicine. Not that I necessarily see all of this every day, but that it would be like not surprising to treat something like this in a typical day in family medicine. So as you can tell, it's not just, blood pressure and diabetes. We really do treat quite a bit. So in my opinion, it doesn't get boring because you've got a lot to do. Okay, so a little bit about me outside of work. I'm actually married to my high school sweetheart. He is not in medicine, he's a pastor. Again, we moved for his job. We've got 2 cats, no kids right now. Outside of, work life, I like to spend time outdoors, hiking. I like to read, cook, hang out in coffee shops when we're not in a pandemic. And then earlier this year, I started my Instagram page, which is how Pre-PAPals found me. Essentially, that was twofold. Where I previously lived, a lot of my friends were outside of the medical field. So that was me kind of pursuing a community of other medical professionals, as well as putting out educational content, because I think whether we like it or not, patients do get health information from social media. And I wanted to be putting out, reliable and trustworthy information. So that's been a fun side project, especially with the pandemic going on and not being able to do some of my other hobbies. Okay, so just disclosures before we get started. Any opinions that I express are mine, not my employer's. I don't have any financial disclosures. I'm not compensated for anything outside of my regular clinical job. Okay, so our first case presentation is a rash. And this is a very common chief complaint for family medicine. I have a rash. So we have Mr. G. He's a 75-year-old Hispanic male coming to the clinic for a rash. He reports it started 2 days ago. It's located on the right side of his chest and his back. He states it's burning in quality and has interfered with his sleep. And he has a little bit of itching, but the main issue that he's having is the burning. He doesn't report any significant past medical history, but 2 days ago, he saw another provider in the clinic for abdominal pain. The provider ordered an abdominal ultrasound that was unremarkable. He thinks he may be having an allergic reaction to the ultrasound gel, as the rash started later that evening after he had the ultrasound. So on our exam, his skin, he has grouped vesicles, which are kind of these raised bubbling lesions on an erythematous base. That's the red kind of patchiness underneath it, located in a distinct distribution on the right side of the trunk and on the right side of the back. It doesn't cross the midline, it's non-tender, and the remainder of his exam is normal along with his vital sign. And these are from Google, they're not my real patient, just to disclose that. So I'll kind of explain what a differential diagnosis is, just because I know not everyone on here may be in the same place as far as your medical education. So the differential diagnosis is basically the process of considering what specific diseases could be causing the patient's symptoms. So before you kind of settle on what you think is going on, you need to think about all the possibilities and what else is going on. So in the case of a rash, we're looking at everything that's going on with this patient. So the appearance, which you saw on the slide back there, the location, so it's on his abdomen and back, it's only on the right side of the body. Precipitating factors, so he's saying this started after he got an ultrasound, and the other characteristics that he describes, like the burning and the itching. So you're kind of putting the puzzle pieces together and saying, okay, what does this sound like? A lot of times patients will come in kind of with their own differential diagnosis and their own idea of what's going on. In this case, patient thinks it's an allergic reaction to the ultrasound gel, but that is not the case. So we're gonna skip over to the next slide. And he's actually got shingles, which is herpes zoster, is the kind of medical name for it. This is a viral infection and a viral rash. It's due to the reactivation of varicella zoster virus, which is the virus that causes chickenpox. So initially, it's very typical that you'll see chickenpox in childhood, and then later in the 50s or 60s, it'll flare back up as shingles. The patient may or may not remember having chickenpox. So you do have to have chickenpox to get shingles later in life, but because of how prevalent it is and because they may have been real young when they got it, they may say that they haven't had it. So that's just something to keep in mind. I made a note here that the chickenpox vaccine first came out in 1995. So a lot of our patients who were born before then have not been vaccinated against the chickenpox. So something to think about. The most important risk factor for shingles or herpes zoster is advanced age, in this case over 50. Typically presents exactly how we saw in that picture. So the erythema, which is the red patches, and then the vesicles, which are kind of those raised, almost bubble-looking lesions, usually form over 2 to 3 days. They run in a dermatomal distribution, which I'll explain on the next slide, but like we saw in that picture, very distinct, and rarely crosses the midline. So the midline of the body, the center, I've seen where it can, but in most uncomplicated cases, it's just going to be on that one side. These are very painful. Neuritis is the inflammation of the nerve. So this is a nerve pain based on the virus being in the nerve root. And usually pain is present before they even have a rash, which can sometimes lead to misdiagnosis because the patient will have pain, but nothing on the skin that would suggest shingles. So in this case, he came in 2 days prior with abdominal pain. His ultrasound was normal. It was most likely the prodromal pain to his shingles rather than, actual intra-abdominal issues. So this is what we mean when we talk about a dermatomal distribution. And I kind of highlighted with this glitter marker where his rash actually was. So when you see the dermatome map kind of broken down, you can tell that his rash on the left side being on the front of the body and then on the right side being on the back of the body stayed confined to just those 2 dermatomes. So again, if you see something in distribution like that, or it's just on one side of the body and it's real defined, that's a good clue to shingles. So our treatment plan for Mr. G, he has uncomplicated herpes zoster, which is shingles. There are certain cases it would be more complicated that we treat differently, but for our purposes, he has uncomplicated shingles. So we treat this with antivirals, most effective if you catch it within the first 48 hours, but as long as new lesions are coming up, you want to go ahead and initiate treatment. In this case, I did valcyclovir, which is Valtrex. The reason for that was just because it's 3 times a day, whereas the other one is 5 times a day, so it's a little easier on the patient. Studies show that all the antivirals are basically the same in efficacy. For pain control, we did alternating ibuprofen and acetaminophen, and I also gave him some topical lidocaine. Some patients with more severe cases do need stronger pain medicine. A point of patient education to prevent transmission, because this is a contagious disease. You want to keep the rash covered, do hand hygiene, and avoid those who are immunocompromised or pregnant, because they are contagious until the rash has crusted over. I believe that's the end of our first case study. Are there any questions in the chat box at this point?
Yeah, so there were a couple questions.
Okay.
So Jenna was asking, at what point would you refer patients to a specialist? So I guess in this case, you would refer them to a dermatologist?
Yes. If the question is about like this case study in particular, probably so in more complicated cases, if they weren't responding to treatment, you might refer them to infectious disease, like if they're just not responding at all to the antivirals that you're giving them, or dermatology if they're having persistent skin manifestations, or in some cases shingles can cause chronic pain. So if they're having chronic pain that persists long after their infection, pain management would also be an option. If that's just a general question like about family medicine in general, it's really, in my experience, up to the provider's comfort level. So I'll kind of touch on this later in the presentation, but in family medicine, a little about a lot, if that makes sense. So you're not the expert in anything. You kind of have the most broad scope, but not the most deep. So in that case, if I'm not familiar with the condition or the stuff that I know to do has not worked for the patient, then we'll consider a specialty referral, or if it's just something that I don't treat or that is not appropriate for family medicine. Anything else?
Awesome. So yeah, just 2 more if you don't mind.
Okay, sure.
So somebody is asking, did you recognize the rash immediately, or did it take more consideration to diagnose?
So I recognized it pretty immediately, just because, with experience, you'll see that shingles kind of has that distinct look. But some of my big clues and why I kind of brought in the piece of talking about the differential diagnosis. If this was an allergic reaction like he was thinking, it would be more so all over the abdomen, and it wouldn't be on his back because the ultrasound probe wouldn't have gone back there. That was kind of my main reason for bringing that up. But yeah, shingles has a very characteristic appearance.
Okay, perfect. And then somebody else is asking, how can you check if you have or hadn't had chickenpox? And then the only other question right now is, could any complications arise from the rash-like infection?
So checking if you have or hadn't had chickenpox would probably be with an antibody titer. I've never had that come up where I would have to check it. I would say most people, if they haven't been vaccinated for it, have probably had it, just because of how contagious this is and how prevalent it used to be. What was the next question?
Oh, sorry. It was, could any complications arise from the rash-like infection?
Yes. So So especially like if a patient is putting steroid cream on the rash, like hydrocortisone that's just over the counter, they can get what we would call a secondary bacterial infection. That could also come from, you know, a patient who's kind of messing with the rash a lot, like scratching it. It can get infected from that as well. That would be, you know, the main complication. The other complications that I kind of alluded to with shingles is that it can get in the eye, so there can be ocular involvement, and at that point they would need to see an ophthalmologist or like a dedicated eye doctor to handle that complication. The other big complication that we see with shingles that I kind of spoke on is called post-herpetic neuralgia, which is that chronic pain that the patient has, like where the rash was long after the shingles infection is gone. So those are some of the complications that we see with shingles. Fortunately, this patient did well.
Awesome. And there were a couple more questions, but they were more general. So I'll just hang on to those until the Q&A, if that's okay with you.
Till the end. Okay, perfect. All right, so we will go into our second case study. So this one was very focused. The second one that I'm going into goes a little bit more in depth, so just hang with me. Okay, so this, like I mentioned, family medicine carries the full scope of all ages. So in this one, it's going to be pediatrics. So we have Kay. She's a 10-year-old Caucasian female, past medical history of ADHD. She's presenting with her mom to establish care after they just moved to the area. Mom's main concern is that the patient is not sleeping well. She said she's always been a, quote, bad sleeper, but symptoms are worse lately. She said she's sometimes up until 2 a.m. without apparent reason. The mom has tried giving her Benadryl and melatonin without much benefit. When I talked to the patient, she states that she's just worried, and upon further questioning, she's also worried during the day, so these symptoms aren't just limited to nighttime. And mom states she's also been irritable and lashing out at home and kind of acting out too. Her symptoms have been present for more than 6 months. Mom reports several new stressors for the patient, including parents' divorce. They just moved. She started a new school. She's living with extended family. She was also a passenger in a motor vehicle collision earlier this year. The motor vehicle collision was mild and nobody was injured, but mom has now noticed that the patient is visibly on edge during car rides, and she continues to express worry about getting in another crash. So going through her medical history, she has ADHD and seasonal allergies, both well controlled. She takes Vyvanse, which is lisdexamfetamine, which is a stimulant treatment for ADHD. This was managed by her previous pediatrician before she moved to come see me. And she's been on the same dose for more than a year, so she's been doing pretty well. She takes Zyrtec for her allergies, no recent changes there. No medication allergies. On family history, the mom has anxiety, and her vitals all look normal. So going through kind of what I would do a physical exam on in this situation. So I don't suppose I need to read all of this. Most of it's normal, with the exception of I noticed some silver dental caps. And then the main one that we're focusing on for this one is psychiatric. So patient's cooperative. She's got somewhat poor eye contact, but she's not guarded in her responses. She's very responsive, open to conversation. Remember, she's 10, so poor eye contact is not abnormal in this age group. Broad affect, which means she's exhibiting a full range of emotions. She's not agitated. She's not appearing to have any thought disturbance or perceptual disturbance while she's in the office with me. And she denies suicidal ideation, which is something that you want to ask about in any patient with a psychiatric complaint. Okay, so for our differential diagnosis with this one, I'm looking at what conditions can cause sleep disturbance and worrying, because she can't sleep, but she's talking about worrying during the day too. So top of my differential would be generalized anxiety disorder, which was what I ended up diagnosing this patient with. We'll get into that here in a second. Specific phobia. So when she mentions being afraid of getting in the car, well, her anxiety is not limited to just that situation. It's more of like a all day kind of chronic low level anxiety. Depression can also cause sleep disturbance. She didn't have any depressive symptoms other than that. PTSD, but again, the motor vehicle collision wasn't severe. Nobody was injured. She's not like reliving it. She's just kind of anxious that something worse is going to happen. Something with her. So she's on a stimulant medication for her ADHD. Those can cause anxiety. I wasn't super worried about it with this patient in particular because she had been stable on the dose for so long. And usually with kiddos, as they get older and kind of gain weight, their dose will become less effective. So it'd be unlikely that it would suddenly be causing side effects at that same dose that she had been on. ADHD itself can cause sleep disturbances and can cause anxiety, but again, usually the anxiety that I see with that is limited to certain situations where this patient is feeling kind of anxious and restless all the time. Otherwise, primary insomnia, which just means she can't sleep and there's not really any obvious explanation for it. But again, she's worried during the day too. So I don't think that this is just insomnia. So if we can kind of enlarge this, this is the diagnostic criteria for generalized anxiety disorder. This is out of the DSM-5, which is the manual that we use in psychiatry that kind of outlines diagnostic criteria for every psychiatric illness. It's really helpful because it will explicitly say what the patient is going through in order for them to be diagnosed as this and what you must rule out. So point A, excessive anxiety and worry on more days than not for at least 6 months about a number of events and activities. So our patient met that. She finds it difficult to control the worry. She met that. Associated with 3 or more of the following symptoms. But the little caveat there is that only one item is required in children. Number 6, sleep disturbance. That's the patient's chief complaint. So she meets that. But she's also having difficulty concentrating and irritability. So again, that criteria is met. Symptoms must cause clinically significant distress or impairment. Obviously, if she's not sleeping, that's clinically significant. Disturbance is not attributable to the effects of a substance. That's what I was talking about with her ADHD medicine. Again, I didn't think it was an issue for this patient. And the disturbance is not better explained by another mental disorder. So again, like PTSD, specific phobia, OCD, panic, social anxiety. Generalized anxiety disorder is chronic and kind of present no matter what the situation, where some of those other ones only flare up in certain circumstances. Okay, so we ended up diagnosing Kay with generalized anxiety disorder. I did start her on sertraline. The brand name of that is Zoloft. This is an SSRI antidepressant that is also first line for anxiety. So even though she wasn't experiencing depression, this medicine is considered first line for both. Our 2 big counseling points for this. Number 1 is the black box warning for suicidality in children and teens. So that's something that you want to counsel any parent on. The thought behind that is that in teens and children with depression, that their physical symptoms improve before their mood symptoms. So they may be like at an increased risk of carrying out a suicide plan. This is rare, but definitely important to disclose to parents and patients so that they can come up with a plan for safety. The other counseling point that I mentioned is that this medicine takes about 4 to 6 weeks to take effect. They may notice a benefit after about 2, but we recommend a trial of at least 4 to 6 weeks if they're tolerating it without side effects before we consider, changing anything. I referred her to our behavioral health counselor. In my clinic, we were fortunate enough to have a counselor who comes on site. So that was, it's good that we worked really well with her. And we discussed sleep hygiene measures. I didn't harp on it a bunch because the patient had been dealing with this for like 6 months. So the mom had already tried most of this. So she was already doing no screens in the bedroom, going to bed at the same time every night. Doing like a bedtime routine. All of that is important to discuss. again, if they're not doing it already. And that's part of why we went ahead and started medication, was because a lot of these conservative measures had not worked. In regards to the medication, clinical trials have generally shown that an SSRI antidepressant plus counseling is associated with better outcomes than either one on its own, but this should be an individual decision with each patient and family. In some cases, it would probably be reasonable to start with counseling first, but based on this patient's symptoms and the fact that the mom was comfortable with it, we did go ahead and initiate the medication. So at her 1-month follow-up appointment, she's feeling a lot better. She's doing well with counseling. She's not noticeably worried throughout the day. She's not afraid of getting in the car anymore, which was a really good outcome measure because that was like something tangible that she was experiencing. Her school performance has improved and her mood and behavior at home are also improved. She's falling asleep without difficulty now, but she's waking up in the middle of the night after about 4 hours of sleep. So it's not so much that her worries are keeping her up, but she can't stay asleep. So in this case, I kind of wondered if something else was going on, like we talked about on the couple of slides prior. ADHD itself can cause insomnia. A lot of the times I do see ADHD patients who have trouble sleeping just because of the fact that ADHD, your brain is hyperactive. So at this point, I added a medicine called clonidine at bedtime. And that's an FDA-approved medicine for ADHD that can have the effect of promoting sleep. It's a non-stimulant, so it kind of helps just quiet the brain and prepare it for sleep. And after that addition, she did pretty well. Okay. I believe that's the end of the second case study. Now would be a good point to stop and see if there's any more questions.
Yeah, there were a few.
Okay.
Let's see.
So somebody asked, kind of similar to the one on the first, but it says, at what point would you refer to a therapist or psychologist for help? Yeah.
So I referred her to a therapist right away because I think that in clinical trials back this up, that the combination does work better than either one on its own. A lot of the times medicine can help some of the physiological symptoms and some of the like thought symptoms, but therapy is where I think you really get to the root of the issue. So usually any patient with psychiatric issues, I refer them to counseling right away. If it was like a psychiatrist, which is a mental health doctor who prescribes medicine, that would be if I felt like they needed a medication that I wasn't familiar with or wasn't comfortable prescribing, or in some cases where we've tried multiple trials of medicine and they're not feeling better, then I would get the psychiatrist's opinion. But as far as counseling, it's first line. I would go for it right away.
Awesome, thank you. And somebody else is asking, for SSRI medication, how long do you generally have the patient on it for? And are there any side effects unique to kids?
So I normally, it's very individualized. So I don't know that I have a flat answer as far as how long I keep them on it. There was a study that showed, but I think the study was for depression, that they recommended being on it at least 9 months, as that was associated with a lower risk of relapse. For anxiety, I'm not sure. But a lot of times, in this case, I would say, a lot of her anxiety was probably related to her life transitions and all that stuff that's going on. And so maybe as her circumstances got a little bit more stable and she was feeling better, we could consider trialing off of the medicine, but sometimes it really is trial and error. As far as SSRI side effects unique to kids, I'm not aware of any outside of some of the normals. So some patients can like have appetite disturbance or sleep disturbance. More likely we see that those things improve, but some people kind of get the other way. especially if kids, if their dose is too high for their weight, they can describe kind of like a zombie-like feeling or kind of like moving sluggishly. I've seen that. And at that point, I kind of like consider backing off the dose or switching to something else.
Okay, awesome. Thank you.
You're welcome.
Somebody else would like to know, did you replace her previous ADHD medicine with clonidine, or did you just add it?
No, they're in conjunction with each other. So the clonidine is pretty much just for like the insomnia that goes with the ADHD. So I kept her on the Vyvanse.
Perfect. And then Becky is asking, what do you tell patients who are not, or I'm sorry, what do you tell parents who are not wanting to do counseling and or medication for their kids?
I haven't run into that because normally, you know, if they're bringing the kid to me, they want to do something. You know, normally they don't say no to counseling because, you know, even if they can't get in to see our counselor, we say, well, consider setting them up with a school counselor, and they'll be on board with that. With medication, you know, it really is kind of like a risk versus benefit. So sometimes we'll say, okay, let's see how they do with just conservative therapy for now, and then bring them back in like 1 to 2 months. And if that did the trick, then okay. If not, then we'll revisit the conversation. But just, I would say, providing them with as much like data as you can as far as studies for like outcomes or risks of, I guess, going without treatment. So ADHD is a big one where we see that the outcomes are worse the later you start medicine. That didn't come into play here, obviously, because she was already on ADHD medicine. So that was handled by her previous pediatrician. But that is like a study that's been done. So I try to offer that information and just kind of discuss with them my line of thinking and why I'm making this recommendation. I think parents in general are put more at ease if you explain why you're doing something and not just say, okay, here's what we're going to do. But as long as the conversation is kept open, it goes better.
Yeah, that's a great point. And kind of piggybacking off of that question, somebody else is asking, if a patient starts ADHD medication, do they have to continue the medicine for the rest of their life?
No, they don't have to. No, again, that's not, I hate saying that I don't have a straightforward answer, but that's a lot of the times what we do in medicine. So I have patients who are on it continuously. I have patients who just take it on days that they go to school, or, you know, in our adolescents and adults, just days that they go to work. I have patients who, you know, take summers off, take weekends off, and then sometimes in adulthood, we can go off of it. Again, it totally depends on how their symptoms are doing and what else they can do. Medication is definitely not the only treatment for ADHD. There's lots of like behavioral stuff that counseling can also work with. So there's no reason that they should have to be on it lifelong. It's very individualized.
Okay, perfect. And our next question is, do you feel there is a lack of psychiatrists in most areas? And do you see a lot of patients who have a difficult time finding psychiatric help?
Yes. Yes. So like I mentioned, my previous job was in a rural clinic in Texas, and rural Texas is not a place that psychiatrists go. That's probably true for most rural areas of the country and maybe even some of the less rural areas. But yes, there's definitely an issue with access to psychiatric care, especially for our patients who are uninsured or have like government assistance insurance. I found that it's hard to get them in to see a specialist also. So that is something that I hope to see change. But in the meantime, equipping primary care providers to handle those psychiatric issues is worthwhile too.
Awesome. And on that note, thank you for choosing this type of case. It seems like a very underrepresented topic, so a lot of people are interested in it.
Oh, thank you.
Yeah, absolutely. So let's see. This person is asking, Mariel is asking, what would happen if she did not get better after the clonidine?
Hmm. I don't know that I have a straightforward answer to that. I would probably just do a thorough review of, what's going on in her life. Like reassessing her anxiety at that point, reassessing how she's doing with counseling, reassessing her sleep hygiene, just kind of reevaluating, okay, is there anywhere else we can make improvements if the medication isn't working? There is another medicine for like similar to the clonidine called guanfacine that we use for the same purpose. And sometimes patients respond better to one or the other. So that could be worth a try too. But kind of digging in and see, okay, am I missing something here would probably be my next step if she wasn't responding to the medicine.
Okay.
Great, thank you.
Yeah, and it seems like those are all of the questions on this case study. So you're clear to proceed whenever you're ready.
Okay, all right. So that's it for the cases. Now I was just kind of going to go over some summary points and some talking points for the PA profession in general. So why you might consider family medicine. So kind of what makes family medicine unique as opposed to some of the other specialties. So if you want to see the same patients regularly, obviously as the primary care provider, we check in with our patients routinely, as opposed to if you're in the ER or the hospital, you take care of them there and then send them back into the community. So continuity, good thing with family medicine. If having a stable schedule is a priority, again, I pretty much know the hours that I'm going to work. If you don't mind delaying gratification. So that's kind of said tongue in cheek, but in family medicine, a lot of times our labs that we order and our imaging can take several days to return, as opposed to in the hospital where you'll get your diagnosis quicker. So if you don't mind, or if you're good, I guess, at identifying what needs to take priority right now, what needs to be solved right now, and what can kind of wait. If you like working with a lot of conditions, but you're okay with not being the expert at any of them. So that kind of alludes to our earlier point of when we would refer out. So a lot of times I'll be able to get them started on treatment, and sometimes they do great. And if there's certain things that either they're not responding to, or if I just think they need the specialist eyes on them, then we refer out. If you have high attention to detail, so as primary care provider, you're most likely the patient's first point of contact for everything. So there's a lot of organizing all the patient's health information, reviewing all their specialist notes, reviewing all their health maintenance. What are they due for? Are they due for a mammogram? Are they due for a colonoscopy? What family history do they have that would make them need maybe a test to identify something they're at high risk for? So a lot of managing kind of all the aspects of the patient's medical care is something that we do in family medicine. And then my next slide is just my next couple of slides, I guess, are just tips that I have for students from the experiences that I've been through. So starting with before PA school, which is where I assume you all are at right now, my big couple points. So there's a lot of different paths to becoming a PA. I encourage you to don't do something that you hate because you think it would boost your resume, but focus on your interests and what you can contribute value to. For example, I started out as a biology major, which is great if that's your thing. It was not my thing. And I had this moment where I was thinking, well, if heaven forbid PA school doesn't work out, I want to get a degree in something that I'm highly interested in, which ended up being health science, which focuses more on human exercise, nutrition, along with, your core science classes. But basically, there's no right path. Focus on what you think you'll bring value to and what will bring value to you, not just what you think is going to look good on a resume. Next thing, know why you want to be a PA. So what's your motivation? This is not just important for interviews, because this will for sure come up in your interview, but just for discerning your career in general. So you need to clearly understand the role of a PA, how it differs from healthcare providers, why PA is better for you. Again, you can have work-life balance in any career, so I kind of throw that out the window. Focus on what the difference is between the different roles and where you see yourself, not so much what you think your life could be like in either one. So during PA school, my biggest piece of advice, keep an open mind, always be willing to learn more about a topic. I did not think I was going to like my emergency medicine rotation. That wasn't where I saw myself, but I ended up loving it because it teaches you to think fast on your feet. It teaches you to be able to do anything that walks through the door, which is also applicable to family medicine. Sometimes people come in with emergencies, even though they should be in the ER. So it's relevant. So my point in saying all that is just to see the value in everything and don't just write everything off because you think you won't end up doing it, because you might. Seek out mentorship opportunities with other medical professionals who have been down this road before, and maintain a strong support system too. That was actually something that I got asked in one of my PA school interviews was, what is your support system like? Because this is a stressful time and you're gonna need that support system. That kind of segues into my next point. Make sure that you're taking breaks, even if they're short. So like, for example, Friday night was my I'm not studying night of the week. And continue to prioritize other things that matter to you outside of school. A lot of us in medicine are perfectionists and achievers, and it's really easy to, burn yourself out if you're just studying as much as you can, because there will always be more to study. But make it a priority to do things that you enjoy too, because that'll help with your mental health in school. After PA school, so again, I've been out of school for about 2 years, so you're really seeing what a new grad in family medicine is like. My number one piece of advice for your first job is to look at the environment and the people that you're working with. Specifically, you're a supervising physician. You're not going to know everything when you first get out of PA school, and the environment that you're going to be learning in for that first job is going to put you on the right path to your future practice. I encourage involvement in your national and state organization. I don't know if y'all know what AAPA is. That's the American Academy of PAs. Basically, they do all of our advocacy, promoting of our profession, and I highly encourage PAs to be involved with them. And then my last point, just that learning in medicine is lifelong. Stay humble, continue to grow into your practice style. There will always be things that you don't know that you can learn. And then there will always be things that you thought you knew that might change. So you will never stop being a student. I think that's one of the best things about medicine. And with that is all I have for us. Are there any other questions right now?
Awesome. Thank you so much. Yeah, there are quite a few questions.
Okay.
Let's see. Anahi wants to know, how and when do you choose your focus / concentration? So for example, family medicine, oncology, pediatrics, etc.
Mm-hmm. So the great thing about PAs is that we have the flexibility to theoretically work in whatever specialty we want, in the sense that you don't have to pick it during school. I knew pretty early on in clinical year that was what I wanted to do. That being said, while I was, applying for jobs, I applied to more specialties than just one. Thankfully, family medicine was the one that ended up working out, but it's really kind of up to you. You may know even before you go into PA school what you think you want to do. I still encourage you to keep an open mind during rotations, because you're going to learn a lot about medicine in general, regardless of if that's not the specialty that you want to go into. But there's no set point where you have to know. It's really just when you start applying for jobs, okay, what job do I want to apply for? And making connections on your rotations may help with that too.
Awesome, thank you.
Mm-hmm.
So Rochelle would like to know, did you see any major changes in your autonomy as a PA when you moved states?
So I haven't started my job here yet. I would think that it wouldn't be very different, based on what I've read about the state laws. But I think it's more practice dependent. Family medicine is a field where I feel like we have a lot of autonomy, just because in the surgical specialties, you're going to be working directly with the surgeon, whereas in family medicine, you manage your own panel of patients most of the time.
Awesome. That's a good point. Let's see. T is asking, did you struggle with time management in PA school? And do you have any tips on it and avoiding burnout?
Yes, I would say I did, in the sense that I probably tried to invest too much of my time in studying. As far as tips, so none that I have prepared, aside from, what I talked about as far as setting a time apart to like take a break. The other thing that I would add is this is almost like a work smarter, not harder type of thing, is like some of your classmates will be good at certain things. And I would encourage you to work collaboratively with them, because think about how inefficient it is, I guess, for 40 people to all like make their own study guide. In our class, we had certain people who liked to make like different materials for studying that they would then share via like Google Drive with the rest of our class. And that, I think, helped a lot, because then your time can be spent doing other things if you're not just kind of like redundantly creating your material all over again. So working collaboratively with your classmates is a big one. A lot of programs will probably talk to you about how to manage your time just in that initial orientation, because PA school is such a big monster that no one's ever dealt with before until you get there. So a lot of it too will depend on how your program schedules things out. But eventually, I would say you'll get into a flow of kind of what works for you. Like in my program, everything was in like 2 to 4 week blocks. So I would kind of know, okay, at the end of week 1, here's where I need to be, and kind of pace myself throughout that week. And then, okay, midweek through week 2, here's where I need to be. So a lot of it comes with experience and getting used to your flow. It's different than undergrad. You'll have to kind of adjust to that. But it's just something that everyone kind of figures out on their own.
Awesome. That's a great way to kind of tie that into the teamwork aspect of PA.
Yeah, for sure.
So somebody else is asking, do a lot of new grad PAs work in family medicine to start their career before going into a different specialty? And then they also say, because it kind of touches on every aspect of medicine.
It depends. I think I'm the only one in my class who actually did. Again, some people are just not interested in it, but I do know of a lot of people either who I worked with on rotations, or who gave us lectures at school or whatever, who did like work in family medicine for 1 to 2 years and then go off and do something else. But it's really about what you're interested in. If family medicine isn't an interest for you, there's no reason that you have to, pursue that right out of school. You can pursue a specialty. Lots of my classmates did.
Awesome. And Haneen is asking, did you feel prepared for your first job after PA school, or was it learn as you go?
A little bit of both. So there's definitely going to be learn as you go, no matter what. I think the key is your employer like aware of that? Do they know what to expect? And mine did. They didn't just like throw me in and say, okay, have your own schedule, all like a full day every day. They were very like willing to work with me as a new grad. And that's why I emphasize how much your environment matters, because that kind of support is what you need as a new grad. You've got all that knowledge there, but you're still doing practice for the first time. So there is a little bit of an adjustment. I would say it was probably like it was about a month before I worked up to having a full schedule, and probably a good like 6 months before I actually felt like totally comfortable. And I think that that's pretty typical. I've heard it said that your first 3 to 5 years out of school should be considered like your residency. So still highly, highly learning.
That's awesome. So Becky would like to know, what is something you wished you would have learned in school that could have helped when starting out as a PA?
I definitely had situations like these come up. I can't think of anything off the top of my head. The big one, I would say that we just don't deal with at all in school is like the financial aspect, like billing and coding. So that was a little bit of a learning curve. I totally understand why it's not covered in school, because we have to learn so much anyway clinically that just isn't the priority. But that's something that I feel like I had to have people kind of teach me as I went, as far as insurance isn't going to pay for this if you code it like that, or insurance isn't going to pay for this at all, so don't bother with it. So that's the biggest learning curve, I think, that's not taught in school. But
Yeah, that's a good point. We all live in the same real world, so financials definitely play a big part.
yeah.
Let's see. So Mariel is asking, what are your downsides for being a PA?
Downsides. So for me personally, I would say the biggest downside is people who don't understand what a PA is, or like the value that we bring to the practice. I haven't encountered that a lot, but it is out there. So if you don't like not being like the most respected person in the practice, that might not be the route for you. The other thing, and this doesn't apply to me personally, but if you want to know the most about a particular subject, then that would probably be a physician. Just because like our training is shorter as PAs, and like we work in a team with physicians. I don't know if that makes sense. I'm very happy with my choice as a PA, so I don't really have any downsides personally. But those are like things that I would say to think about.
Yeah, that's perfect. We love to hear that.
Yeah, it's a great answer.
So how are we doing on time? There's maybe 3 more questions, if that's okay with you.
Oh yeah, go ahead.
Awesome. So Vivian is asking, how much harder was PA school than undergrad? I know you said it's kind of a different beast, but if you could just elaborate on that a little bit.
Yeah. So it was harder in the sense that it's very fast paced, and just the sheer volume that you're taking, and like the schedule. So our schedule was pretty much either 8 to 5 or 9 to 5. And in college, like in undergrad, that's not what you're doing. You'll have an hour here, an hour here, an hour here, and then you'll have some time off in between. So that was an adjustment. But the thing that I think made it a little bit easier is that, so a couple of things, you're working with the same professors your whole time. So you get used to your professor style. You're able to kind of understand how they write questions, how they teach. And each module kind of flows similarly, like I was talking about. So instead of taking like 6 or 7 classes at a time like I did in college, I was able to like really focus on just the one for 2 to 4 weeks, and then move on to the next. So in that sense, it was almost easier, just as far as managing what all you need to do. So there's ways it's easier and there's ways it's harder. You'll adjust. It is an adjustment period, and they understand that, the faculty do.
All right, thank you for that. And Bill is asking, are fellowships something supplemental, or are there any like required schooling that's extra for becoming a family medicine PA?
I'm not sure if there are any family medicine fellowships. It wasn't something that I looked into after school. They are, it's totally kind of up to your preference. Some people do them mostly for certain specialties to kind of, if you know that that's the specialty that you want to do, then I would go for it just to kind of make yourself a more marketable applicant. But I don't know anyone who has done it apart from like people that I see on social media. I don't know anybody personally who's done it. They're not necessary.
All right,
Awesome.
I don't know if it'll change in the future, but for now they're not.
All right, I think this is a great one to end it on.
Okay.
So they're just asking, what is your opinion on the future of PA? So if you could discuss like salary, oversaturation, the role they play in medicine, that kind of thing.
Everything that I've seen is that the projection is that the need will continue to rise and that PAs will continue to be utilized. Oversaturation is a bit of a concern to me, but it kind of depends on the area where you want to practice too. So there's a lot of larger cities, I would say, where job searching is kind of difficult because of oversaturation. But if you're willing to go somewhere else, that's not really an issue. I definitely, hope that the powers that be, as far as our national organization, are kind of keeping an eye on that and, not letting all these schools explode and produce more graduates than there are opportunities for. But I think that opportunities for PAs will continue to be there from everything that I've seen and read. It's hard to predict some things happening like pandemics and whatnot, but I think the future is pretty good. That's another reason why I kind of harped on this point at the end to get involved in AAPA, because they are like our organization for like all the state legislation and like promoting our scope, making sure that we can practice at our scope, making sure that there is a role for us in the healthcare system. So I think that's looking good, but I encourage all PAs to like participate in that and advocate for your own profession like any other profession would.
All right, I think that's a great food for thought kind of thing to end it on. Thank you so much, Kaitlin. That was an amazing session. A lot of great information.
For sure.
Well, thank you. I enjoyed talking with you all and hope that it was somewhat helpful.
Absolutely. And we know you were kind of focused on your presentation, but you might go back later and just kind of look over the chat if you want to. But just to kind of give you an idea, there was so much support here. A lot of people were saying thank you. They really appreciate you doing this. Compliment your attitude, great tips, all this kind of stuff. So.
Well, thank you guys.
Absolutely.
I really enjoyed it. Maybe we'll be able to do this again sometime.
Sure, we'd love to have you back.
That'd be awesome.
Okay.
You had amazing answers to all that. There were a lot of questions, and some people were really trying to put you on the spot. So you did really good.
Thanks.
We can tell you've been through the interview process a time or two.
Yeah.
All right. Well, thank you so much. We really appreciate it.
Thanks. Have a good night.
All right. Have a great night.
Bye.
Bye.
All right, everybody. Thank you so much, as always, for being here. We really appreciate you taking the time to join us. Let's see. The quiz is posted, I believe, or will be posted in just a second here. So yeah, the same details as usual. You just need to make 4 out of 5 in order to receive the certificate, which will be emailed to you within a week, but we're usually a little bit quicker, so maybe 2 to 3 days. It's nothing tricky. Everything that she's talked about. So we try and make it straightforward, just to kind of make sure that you were engaged in the presentation, not to like trip you up and like, something like that.
We just want to make sure you kind of did see it, or if there's something that you could learn from it or take away, we kind of want to emphasize some of those points. But yep, like I said, same thing. As long as you get 4 out of 5 correct, we'll email you that certificate. It usually takes us about 2 to 3 days.
Yeah, and stay tuned on our Instagram. We have a lot of sessions coming up, where our next session is on the 19th. So yeah, Thursday. That'll be at 6 p.m. Central. We will post that to Instagram as well as all the coming sessions. We have quite a bit in November. I know we keep telling you guys, but just a good way for you all to get experience, exposure to a lot of different specialties. We'll have a psych PA coming on eventually, I think within the next coming week. So if you guys have any requests for any type of PA that you want to ask or that you want us to reach out to or a specialty that we haven't covered, let us know. Reach out to us on Instagram. We'd be more than happy to try and put something together for you guys. Trying to think. I think that's pretty much everything, but yeah, really thank you so much. We really appreciate all the support. You guys are just too kind. We really appreciate it. And for Kaitlin, we'll go ahead and put her Instagram as well as her, you know, contact information, that kind of stuff. We'll insert that into the chat just in case you guys want to follow her. She does post some pretty cool videos and little tips for you guys, that kind of stuff.
Yeah, a lot of educational posts. Good to know.
Yeah, but on that note, guys, thank you so much. Really appreciate it. We'll see you next time. We'll be hanging out right here in the chat. If you have any questions for us, just let us know.
Thank
All
you.
right,
Have a
take
good
care.
night.
Good night.